We have a panel and we have our presenters. They will introduce themselves as they come on stage. I'm Elsie Kiguli-Malwadde. I'm from Uganda. And we have David Marsh from Canada. We have Narelle from Australia and Henry from Brazil. Okay. So we'll begin with our first presenter. Where's the list? Okay. Afdal Kunting.
Bismillahirrahmanirrahim. Alhamdulillah. Assalatu wassalamu ala Rasulullah. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Friends, good morning. Good morning. Friends, what do you do when out of the box is not enough? My university, the Ateneo de Zamboanga University School of Medicine, started in 1994 with what was then a radical out-of-the-box curriculum. So we use PBL for classroom teaching and send students on a longitudinal 2-year exposure in rural and remote communities. Now, this was a region that is one of the most unstable and poorest in the country. So in the communities, students would work with community leaders to establish a comprehensive community health plan to address their identified health needs. So a key component here is a strong collaboration with people who I'd like to call our traditional allies. So we work with teachers for health education, social workers for nutrition programs, and agriculturists for food security. So to name a few. So you can say we've been successful along those lines. However, there are still some issues. So safe water is still a major problem. Sanitation and waste management still contribute to a lot of our diseases. And don't get me started on data. It's a major issue. So you can say, in a sense, that our out-of-the-box approach is inadequate to deal with some of these social determinants of health. So perhaps it's time to start working with non-traditional allies. Enter the College of Biomedical Engineering. So biomedical engineering was the brainchild of our dean in the medical school, Dr. Cristobal. And so a unique aspect of their curriculum is their students also go to rural communities together with our medical students. So they would look at the CHP, they'll work together to identify components in which they can put in biomedical solutions or just plain engineering concepts. So after about a year's work, they're now looking at geographical tagging of diseases for for targeted interventions. They're looking at developing mobile phone applications to gather data, or just gadgets for early disease detection. These are on top of what we call traditional solutions like better pumps, waste disposal management systems, and stuff like that. So friends, it's an exciting time for us now at the Ateneo as we look forward to the fruits of this collaboration. We're hoping that this partnership will bring more lasting change and better health outcomes for our people. Thank you.
Thank you very much. Yeah, that is interprofessional and impressive. I just have one question for you. How do you involve local administration or government in your collaboration? A microphone for him, please.
Well, it's more of a university thing. Right now, it's between 2 colleges. But I think in the future, it would be important to deal with the local government units because changes can't be done purely on the university side. So whatever things that we do, it's very important for sustainability to get the local governments, the mayors, the people that make the laws as part of the decision-making process. We're not there yet right now because we're starting, but for sure, we'll be going that route.
Can I invite Godwin?
Good morning all. The topic of my talk is social accountability at death. And I would like you to imagine the amount of progress that we might make in achieving universal health care if a part of family resources spent on funeral ceremonies is used to address community needs. Just reflect on the numbers that you see on the screen. In the US, funeral costs range from $2,000 to $10,000, and in the UK, £3,000 to £12,000. And in Kenya, Cameroon, South Africa, Nigeria, and other African countries, elaborate, expensive, and massive burial resources are common. And here is the point. If a part of these funeral expenses is channeled to addressing health needs of communities, of course, the burden of disease and death may reduce. My family had funeral ceremonies in 2017 and 2018, and we thought we made a difference. You may ask, how? Well, of course, we had food and drinks, we had music, we had expensive casket, but we entertained, and of course we entertained thousands of guests. But beyond the food, beyond the music, beyond the gorgeous dressing, beyond the expensive caskets, we provided free medical services, free dental services, free eye care services to about 1,000 community members who lived where our parents lived and died. What are the next steps? As a family, we plan to continue to celebrate the life lived by our parents. This year, we will be hosting the first memorial lecture of our father on the topic, the road to aging, navigating the terrain and negotiating the curves. And we have outlined future activities that will include renovation of schools and scholarship awards to community members. In conclusion, I would like to say that the celebration of the life lived by the dead can be an avenue to extend health, life, and well-being to the living. We can save lives by using a portion of the funeral expenses to support community needs. Thank you.
Thank you very much. Can I ask you a question?
Yes.
So do you think this has potential to be extended beyond the work that you have done to convince families that the portion of the expenses could be put to other uses?
Yes. Soon after our programs, we've had several contacts requesting us to help them coordinate similar activities in their communities. So I see a lot of potentials on this.
Fantastic, thank you.
It's my pleasure to introduce Alex Anawati and Maureen Mclelland.
So as an ERMD that works at a regional academic health sciences center, I see a lot of people walk through the door with the same root cause to their health problems: poverty, poor access to care, addictions, social stigma, discrimination. And these root causes haunted me to the point where I began to wonder, can a social accountability framework similar to the one used in medical schools also apply to my health institution to help us better understand the priority health needs and impact them of our people? It turned out I wasn't the only one that saw the need for a social accountability framework. Let me share with you today the 5 ingredients that led to Health Sciences North to declare its need to be socially accountable. The first ingredient was a social accountability based medical school. We have the Northern Ontario School of Medicine in our region. It laid the foundation for social accountability, and it's a world leader in social accountability medical education, and it's one of our partners. The second ingredient was to create fertile ground. Social accountability was cultivated at Health Sciences North in the minds of our learners, our frontline healthcare staff, and our community. The third ingredient was winning the Social Accountability Leadership Lottery. In October 2017, we hired a new CEO, Dominique Giroux, who knew what social accountability was because he used to be the chair of the board of directors of the medical school. He went on to appoint my co-presenter here today, Maureen Mclelland, as the special advisor to the strategic plan. And we were fortunate because Maureen brought with her a strong background in social justice and health equity. The fourth ingredient was a call to action campaign. I drafted a call to action asking the Health Sciences North to accept social accountability as a top priority. And in this call to action, I asked the institution to go out and engage with the people that it serves to identify their priority health needs.
The fifth and final ingredient was the process itself. The process for strategic planning was designed to be engaging, opening doors and opening minds. We targeted the unusual suspects in our planning process, extending opportunity to engage directly in community with individuals and groups that would not normally be considered in a planning process. These included our Indigenous communities, marginalized communities such as people living with mental illness and addiction, and some of our marginalized youth, LGBTQ community as an example, in addition to frail seniors. And through this process, and because of the call of action that had occurred, people felt quite open and safe, challenging the hospital to act and work in different ways. And the end result, social accountability emerged as the second highest priority in our strategic plan, something that both inside and outside the hospital, our regional academic health science center, people latched onto and said, this is important and this is the future we want to lead. And as a result of that, the goal of being socially accountable has been called out. It has been called out with key outcomes and deliverables that we are expected to achieve in the next 5 years. And our leadership structure has changed in a fashion that will allow this work to be supported. So the infrastructure has changed to make this possible. We'd like to thank you and certainly open up to any questions that you may have. We'd like to come back in future years to share with you the progress that we're making to be a socially accountable health organization. Thank you.
Thank you. Of course, it's fate that I will be the one who gets to introduce you and ask the question. What do you see as the biggest implementation barriers for actually driving forward change?
I think it's what we've talked about in the last few days here. It's not a different barrier. It's the same shift in attitude to get people thinking that the solutions lie in the people that have the lived experience. And chipping away at professional elitism is going to be one of our biggest barriers. Having people open their ears to listen to the solution that might be right in front of them from a strength-based approach is something that we need to continue to strive in terms of how we develop our staff so that they can listen to the answer that may be right in front of them. If I could just, we have some USB sticks and copies of our strat plan. Happy to share them with anybody that would like copies at the end of the session. Thank you.
My pleasure to introduce Annie Farthing.
Good morning. I'm going to talk about Tangentyere Council Tangentyere Council is an Aboriginal community-controlled council which provides social services to Aboriginal people in Alice Springs, about 1,600 kilometres south of here. I'm going to tell you why Tangentyere runs a chronic disease service in the community rather than in a clinic. It's because it allows focus on those non-medical factors which contribute to developing the chronic diseases in the first place. And I'm going to talk about how this community-based service can address some of the social determinants of health, such as income, transport, housing, and meaningful activity. This is our Centrelink or welfare office in Alice Springs. All the clients who use the chronic disease service are on welfare. Often I turn up to clients to take them to appointments, to their echocardiogram or specialist appointment, and they tell me that they have been cut off from their welfare payments and haven't eaten for 2 days. So sometimes we go, what's our priority now? Maybe we cancel the medical appointment and go and deal with Centrelink. None of the clients have private vehicles. They all have opportunistic access to transport at best to go to the shops or go to appointments. So sometimes after an appointment with me, we might go to the shop or visit a relative because it allows for an ongoing conversation with people and it also allows our relationship to develop. We have incredibly high rates of overcrowding in many of the public housing and town camps in Alice Springs. Some people have their names on a housing lease, but when you have very few resources, it's very difficult to maintain control over the house. And many don't have their names on a housing lease, which means they're essentially homeless, or we might call it couch surfing, or just relying on other people to put a roof over their heads. The systems that people have to deal with, usually always in English, they come from a Western world viewpoint, rely heavily on access to phone and internet, and assume a level of education. All these are hurdles to actually accessing a service rather than meeting the needs of the clients. So placing a chronic disease service as close to the community as possible enables us to advocate at least for some change. There's also an opportunity outside the clinic to talk about meaningful activity and well-being. There's opportunities to connect with activities that can enhance well-being, such as the cultural engagement in the production of art, and Tangentyere sponsored the very recent Vincent Lingiari Awards. But really, health professionals, we have a lot of great advice, but some of it's neither useful or helpful to people. When we place services as close to home as possible, it shifts the focus to addressing the real challenges that people face in maintaining their health. Thank
you. Well, thank you for this very elegant presentation. I'll give the floor the opportunity to make a question.
That sounds like a fantastic program. I wonder whether there's some KPIs that challenge you that you're meant to account to.
Getting the program, this chronic disease program, relies on implementation of a GP care plan, and sometimes getting the GPs to actually consider what really challenges people on their GP care plan can be tricky. So some GPs are great, and that's often a lot of what we do, is say to the GPs, you know, the most important thing for you to do now is actually write a letter to Centrelink to say this person is not capable of working. Let's support them to get on a disability pension, because then they don't have to keep on going with their obligations to the Australian New Start.
Thank you very much. Next we have Dr. Subodh. You're welcome.
Good morning. A year back, we at Mahatma Gandhi Institute of Medical Sciences at Sevagram partnered with UNICEF to design and implement a program on empowering parents for healthy growth and development of children. This program was to be implemented utilizing existing opportunities within the public sector, and we had to reach a total population of 1.2 million. We were very apprehensive about the mammoth task. It actually meant that we'll have to work with mid-level managers, supervisors, and frontline workers at different levels in different sectors. It was about empowering almost 3,000 frontline workers, not only in clinical and counseling skills, but also on influencing and engaging all possible stakeholders. And all of this without a formal authority and a small project team. At the end of 1 year, we find lots of excitements in almost each of our stakeholders. Every month, almost 30,000 to 40,000 households are being reached with messages on parenting separately through the 3 platforms: home visits, mothers' meetings, and parents' fest. While we were implementing this program, we had several options at each step. But every time we chose the option which expressed maximum confidence and trust between the different stakeholders. First and foremost was developing vision, which was done with all stakeholders together. Regarding the changes in various, we had to do restructuring of various platforms and approaches, and this was done in consultation with all stakeholders. But at the same time, we left enough space for innovations to be done. When the training was designed, it was in consultation with those who were very close to the frontline workers and supervisors. And still, we had enough space for the trainers to innovate within the training program. And we built a culture of appreciative inquiry. So each small success was analyzed, we learned from it, and it was celebrated. So basically, we experienced the power of shared vision, shared decision-making, and a shared belief in the intent and capacity of everyone. And the mantra we learned was, they believe in us as much we believe in them. Thank you.
Thank you very much. I've actually visited Sevegram and I find their work very impressive. In this project, how were the students involved?
At present, medical students are not that much involved in the project because this project is being implemented in districts which are away from Varda, where the medical college is located. But they learn from our experiences and they are able to interact with the project team members. So that is the way they are learning. Thank you.
Thank you. And now I'm pleased to welcome Björg Pálsdóttir. Thank you, Björg.
So just to make sure I know how this works, why are we still talking about equal rights for women? As somebody who comes from a very privileged background in terms of equality, like so many women, I have faced gender discrimination in many firms, including lower salary, sexual harassment, and even rape. However, like many others, I stayed silent. I didn't want to be the whiner, and it wasn't really until millions of women and men voted for a very sexist precedent and disturbingly sexist precedent in the United States, and the Me Too movement, that I thought, oh my God, by staying silent, I've been complicit. So, with the prospect of my daughter going into the world where some things had improved, but the other things were actually worse, I thought, I gotta act. So when the WHO Global Health Workforce Network created a gender equity hub, I joined. So their first task was actually to do a literature review, and obviously the results were not so surprising to many of us. Women make up 70% of the health workforce, yet much of it, including is actually volunteer. Yet they face much discrimination. They actually contribute $3 billion annually, half of it in the form of unpaid work. The challenges include occupational segregation. It's deep and wide. Female professions are usually of lower social value. There is a large number of women who face discrimination and sexual harassment. And you might not know this. I was shocked to see that 30% of recipients of a National Institute of Health awards actually reported being sexually harassed, compared to 4% of the male recipients. And women working in conflict zone around the world face even more challenges. So gender pay gap is, sorry, I should be looking at this screen. Gender pay gap is obviously something that we hear quite a bit about, and it's something that's chronic. And I think the expectation, if we move at this rate, we will receive equal pay in about 70 years. So there's definitely something to be done about that. Same thing with leadership role. While, as said before, it's 70% of the workforce, we're only in 25% of the leadership roles. And that's only, most of our data actually comes from high or middle income countries. And then there's other disadvantages is that women face, ethnic background, religion, class, caste, etc. So that has a multiplier effect. So one of the things that you can see, as I say, it's a massive report, which is just the beginning, scratching the surface by looking at gender issues in the health workforce. So clearly, what we have to do is we have to actually start looking at unpaid work as a part of health and social workforce. We have to look at increase the data collection, and we have to disaggregate data to try to understand the reasons. We need to actually measure impact of policies and see where they take us. And we need to prioritize research in low and middle income countries. So this is not a women's issue, and this is not something we can do alone. We need to partner with so many men who believe in what we're doing. This can't be an us and them dialogue. This has to be something that we figure out together so that we actually finally work towards equality and equity for all. So that's it.
Thank you, Björg. I particularly appreciated your solutions approach, because this is a really difficult topic, and one of the things you said struck me like right here. It's like staying silent makes me complicit, and I very much valued that you kind of spoke to the whole audience about this is a men's and a women's issue, so that if we work together we'll get better outcomes. So I don't actually have a question for you. The audience might, but I do want to say thank you for that.
You're welcome.
Does anyone in the audience have a question that they would like to push?
Just a thought. Are you finding that there is actually an essential structural difficulty in bringing women into equality across fronts, because women essentially, perceive community and life differently than the structures around them tend to. I'm almost reflective of what Annie was saying about Aboriginal people in Australia, that kind of context. Sometimes it's just all out of sync. You get that? Or?
Look, I think it depends on context. In some cases, that may be the issue, and that's why this is complex. It may be also, for example, sometimes women may not either see themselves or as leaders, or may not step into it. However, I think there's an underlying structural issues. There are sort of perception, both that are been internalized to some extent, and then there you face these barriers. So one of the things where I feel it's easier for me now to speak up, because otherwise, if you are sort of lower level in the infrastructure, you get seen as a complainer. But I think it is complex. It's behavioral. It is, internalizing stereotypes and perception. Sometimes, speaking from my perspective, and I come from a country which is probably from Iceland, which is seen as one of the leading, the most equitable societies, but you still face this discomfort with power. So, these are luxury problems. We also have countries where the most basic rights, and I think I've listened to some of the presentations about gender violence and perception. What's gender violence? Sometimes it's an accepted practice as part of the cultural construct. So the challenges are very, complex and deep. But I think we need to look at it as societies, because when all of us rise, when we work together and move together, that's when everybody, benefits.
Thank you.
Thank you. Our next speaker is Krista Cockrell.
Talk to you a little bit about Western Sydney University's Rural Interdisciplinary Learning Program, or what we like to call RIPPLE. So what is RIPPLE? RIPPLE is where we take a group of students out to a rural location for a weekend, and we drop them into a series of complex simulation events. Now, these groups of students are generally comprised with medicine, paramedicine, and nursing students. However, recently we've had more involvement from some of the allied health, which is really exciting. So we're trying to adapt our simulations to accommodate that as well. And by complex simulations, I don't just mean high acuity. We do have one high acuity simulation that we engage the students in, but the other simulations might be a palliated patient who wishes to remain at home in a rural or remote community, and the challenges that go along with that. Or it may be a family where they need to take one child into a regional or metropolitan hospital for a specialty, but they still have their social responsibilities of maintaining their home. And the students have to work together to manage these situations, both medically and socially. So at the beginning of the event, we evaluate the students to get their perceptions on interdisciplinary care and how they feel that would benefit them in their practice or their future practice. And then we re-evaluate them at the end of the event to see how their perceptions have changed. And some of the key findings that have come out of this has been an improved appreciation or an increased appreciation for patient-centered care. So we talk about patient-centered care in the classroom, but until they've actually witnessed it through patient actors, they don't quite fully grasp the importance of that. Communication, not just amongst health professionals, but also communication with the patient and involving them in their own care and decision-making, as well as their family members. An importance of providing care in the community whenever possible, so that there is minimal disruption to the patient or their carers' lives. And an improved understanding and appreciation of the layers of care that a patient goes through during their journey, as well as an improved understanding and appreciation of the various health professional roles that are involved. And and an increased recognition for the importance of team-based care in providing a holistic approach to managing your patient or client's health. And they've also gained greater experience on how to initiate team-based care as well. However, our greatest finding to come out of this has been the ripple effect. And this is what we weren't planning on from the beginning in our project. What we've started to notice is an increase in these pop-up, spontaneous interprofessional learning events that are spurred on by the students. So this particular photo, we had walked away to actually clean up because we were, buggered at the end of the day. And we came back to find the students had created their own interdisciplinary learning session. Now, this hasn't come without challenges. One thing that we've learned is that we still have a lot to learn about each other, even those that have been practicing for a long time. And in education, particularly health education, we're quite siloed and we have different pedagogies, which can create some challenges in coming together for these simulations. So our next step is to work on creating some guidance materials around conducting interprofessional education using simulation. And I'd like to invite some of you to get involved with that. I would really love to have some input or some insight from some of your own perspectives when developing that guidance material. So please, if you're interested in getting involved, be sure to contact me. Thank you.
Thanks. One question. What we've found with interprofessional education is that when we do it with learners, they seem to adapt and understand each other's roles well, but once they get into the clinical context where practicing professionals don't practice interprofessional learning, it's harder for them to implement it. Have you had any simulation experiences with the healthcare teams?
So we've only been doing this for a year, so most of our students haven't gone on to graduate and practice yet, so we haven't got longitudinal results. But in our own practice, some of the things that we've found is we actually don't know what a lot of us do. So my very first Ripple, I'm a paramedic, and I was partnered with an oncologist to create a palliated at-home scenario. And we spent a lot of time before the simulation just discussing what each other did. So it's really been a learning curve for us as well. Thanks.
We now have the pleasure to listen to Rosalie Schultz, who's very passionate for her work.
Thank you. I acknowledge the traditional owners of the land that we're on. Many Aboriginal people in remote Australia remain connected and committed to their country, even after over 2 centuries of colonisation by non-Aboriginal people. Surprisingly, perhaps, well-being of Aboriginal people in remote Australia matches that of Australians as a whole, despite adverse socioeconomic indicators. So our project was to explore well-being for Aboriginal people in remote Australia, to provide guidances for services to better meet people's needs. We developed this interplay well-being framework with the government priorities of health, education and employment, and then the community priorities of culture, empowerment and community. Then even within the government priorities of health, education and employment, the community had their own priorities. Health is not measurement, is not the things that we come out of the clinic with. Health is being able to do what you need to do in your life. Education is speaking and writing Aboriginal languages, understanding cultural knowledge and learning on country. And employment is being involved in customary activities, including fishing, hunting and gathering, art and craft, regardless of whether people are paid.
We want to see more young kids out in the country, learning about our culture, our land, instead of being in town and caught up with all the bad things. When we're out in the country, we feel that the spirit and our elders that have gone their spirit is with us as well and guiding us. And I want to see those young boys, girls that are mucking up to be a good person, a good leader and a role model. This is kind of, I guess, time to tell them it's hard, but it's good. You feel good.
Culture is on the front, always. Culture, you won't lose yourself. Culture, you won't lose all the land. Culture, you can dance. Culture is a bird. Culture is everything what we have here in my blood, or even in my bone, or even in my mind, or even in my heart. I got full of culture in my body.
Yo, my name is Kalalingo Kanambar, and this is my Ngarako country.
Thank you.
Very nice. What advice would you give to someone who has a similar change? What's the main ingredient for your success, for being conquered this community's trust?
I think listening to a community and being aware of our own lack of knowledge of other people's lives.
Thank you very much. And next we have Geneviève Moineau. You're welcome.
Bonjour à tous. Good morning. In the next 3 minutes, I'm going to do something very un-Canadian, and that is to brag, but then I will do something very Canadian and offer to become friends and work with you. As you have heard from many colleagues at this conference, Canada has a long time history of commitment to social accountability. At the turn of the century, there was a federal government-supported document that actually really quantified what we meant by our vision for social accountability at our Canadian medical schools. This was further described and shaped into some recommendations around the future of medical education in Canada, both for our MD program education and for residency education. At the Association of Faculties of Medicine of Canada that I'm privileged to lead, we have established, thanks to Robert Boland, who needs no introduction here, an International Social Accountability Award. And you will see here from the recipients that many of your organizations are represented here, including the Northern Ontario School of Medicine. As well, our Canadian institutions, faculties of medicine, have received 5 out of the 7 Aspire Awards, the International Awards for Social Accountability. So Canada really rocks. One of our biggest claim to fame is that we were able to bring into our national accreditation standards for our faculties of medicine, a standard specifically focused on social accountability. We lovingly call it the 1.1.1, and you know, it's number 1 for a reason, 3 times. And that is in fact that a medical school has to actually describe its priority health concerns related to the populations it's meant to serve, and it has to articulate that in its mission statement, and it has to demonstrate how it has incorporated that in all of its aspects, including admissions, curricular content, and the type of experiences that it provides to its students. And most importantly, it has to show that it has the desired outcomes. And so that relates to what the graduates do, where they practice, etc. So this is a very, very difficult standard to uphold, and I'm very proud that our Canadian schools agreed to be held accountable to this standard. Most recently, the AFMC is also very proud to be supporting the recent publication on accreditation excellence for medical schools' impact on population health, again led by Shal Boland, Robert Woolard, and others. We also have been engaging in international collaborations to support other countries and institutions in their work on social accountability and accreditation. And so very happy to have a conversation with you about potential collaborations. We're also very proud that this year, again, our AFMC board and our board are actually the deans of the 17 medical schools, plus we have 4 public members, of which 1 is a learner. But our deans actually unanimously agreed to work on the recommendations of a joint commitment to action in Indigenous health. As you know, in Canada, we have to respond to our Truth and Reconciliation Commission calls to action, and this is going to help our schools actually implement those recommendations. We also are very proud to be the Secretariat for the Franco-Doc project, which is with our partners developing increased capacity for French-speaking health human resources in Canadian minority, Francophone minority communities. And in fact, the Franco-Doc group is here. They're actually presenting in the other room right now, so kudos to them. And lastly, I want to just mention that we have are in the process of undergoing a reflection with a think tank on the future of admissions in Canada. And a big part of this work relates to the importance of increasing the diversity, equity, and inclusion of our successful candidates for medical school. And of course, none of this can happen without the support and encouragement of kindred spirits like many of the organizations represented here today. And of course, why do I get up in the morning? It's for my grandchildren, but also everyone's grandchildren, so that we can actually hopefully leave the world a better place than we found it. Thank you.
Thank you, Geneviève, for sharing with us the success of Canada. Just one question. Well, so many countries are struggling to get to this level. What are some of the things that you think have made Canada successful that other people could take up and probably get to where you are?
Well, thank you very much, Elsie. And of course, you know, here we're talking mainly about education and accreditation, but as has been the subject of so many of your stories, it really relates to the importance of having engagement with government and with the decision makers around the health system. And so again, we are very fortunate to be in a country where, you know, our biggest pride is our universal health care. And again, within the country, we fuss about, you know, it's not as perfect as it sounds, but let's just say it's better than most places. And just a little tidbit. A few years ago, there was a poll done by our Canadian Broadcasting Corporation on who is the most famous Canadian of all. So of course, it was Wayne Gretzky, right? No. Justin Bieber? No. It was Tommy Douglas. And Tommy Douglas is actually the politician who brought universal health care to Canada. He was from Saskatchewan and fought the great fight. There were, you know, doctor strikes, all of that, and he made it happen, and he became a high-level national politician. But so that's how proud we are of our healthcare system, and it really starts with that, and then everything else, you know, falls along. Thank you.
Thank you.
Thank you. Our next presentation is by Samar Ahmed.
Good morning, everyone. I'm Samar Ahmed. I'm from Ain Shams University, Egypt. I'm here representing the Regional Famer Institute in the Middle East, North Africa chapter. And I'm very happy to be very well prepared with a song today. No, I don't have a song. I can't sing. Can't. So actually, instead, I'm going to tell you the story of love. Today, I'm going to speak about the love I got since the year 2011 from Famer Institute. When I was first brought in as a fellow, a very long time ago, and I thought this fellowship was 2 years long. And after that, I get a certificate, and I'm on my way to do great things elsewhere in the world. But actually what happened is that I discovered that Famer became my life, and it still is. And it will continue to be for as long as I'm working in this field. Since 2011, I've been working on creating the effect of the love that I got in Philadelphia, and in expanding that so that many other people can actually feel this and get a sense of this experience otherwhere in the world. For years, I worked towards creating a community that I learned could exist in Philadelphia during my fellowship. This is what they call the community of practice. And we started doing that in our environment back home until finally it was time to actually initiate and start our regional Famer Institute. And it was so celebratory that we did everything as if we had done everything we could do in the world, and we thought that we had achieved it all. Until we started bringing in fellows, and each one of them came with their own dream and their own hope. And it became our responsibility to take care of their dreams and their hopes. And then it was evident that we can't just leave them like that, not showcase the great work that they have done and that they are still doing, because they've all been struggling in their fields and they've all been trying to do great things on their own, and now they have become a part of a big family that has to celebrate their work. So what we thought of was actually what I came to talk about today. What we did was try to showcase their work, and then the main idea was for them to find themselves a portal where they can post whatever it is they want to post, showcase the great work that they're doing, have their friends come in, take a look at the educational resources that they've been working on, and maybe get feedback for that, and maybe improve on that, and feel the amount of freedom that we feel in any Famer program that we are exposed to. We have that degree of freedom to innovate and be great at what we do. So what we did is offer them this portal. This became our YouTube channel. And because it's not part of the requirements of the fellowship, we could not, unfortunately, make sure that everyone has to post a video on that portal. It became not a requirement, and so we couldn't say you have to do this. So I started by posting myself 12 videos, started working on 12 educational videos, and then the fellows, they started chipping in and asking, can we help? And I said, yes, why not? Just go ahead and show me the educational content and we can post it. And then the idea proceeded from there that maybe we have a distant learning component. We call it the MLWeb. The MLWeb distant learning component is a student selected component or a trainee selected component that we wanted to showcase and we wanted to build on. So instead of having a very short written summary of your MLWeb discussion that happens on listserv, why not post this as an educational video? Doing that, we achieve two things. Number one, we make sure your name goes on your work. So your name is there and you have actually developed this work, so your name deserves to be there. Number two is that next year we're going to have other ML Web sessions. So make sure that they reference you and they build on you and they do not repeat these topics. So people started working towards that, posting their own videos. Of course, we had to have a board for quality control. We relied on the ESME, which is the Egyptian, it's a committee, an Egyptian committee for medical educators. We relied on them and their expertise. They would look at the videos. They would say, okay, the educational content is great. Post it. We had a group working on that, and then we decided that we give it over to the fellows. So our 2019 fellows are now completely running this portal, all of it, and today we have 121 videos posted, educational videos posted in less than 1 year. All these videos have been posted, revised, and the educational content has been revised and approved by ESME. So we're very proud of that, and our hope is that anyone who would like their work to be showcased and their work to be seen in our region, to please go ahead and tell us, send us your work. We post 3 to 5 minute videos. Please take out your cameras. Please take out your cameras, your phone cameras, and please scan. It will take you straight to our YouTube channel, and subscribe. When you subscribe, you become part of our family as well. And when you do that, you will have the opportunity to comment and say what you think about our work, and also send us your work, if you think you want your work to be seen in the Middle East. Thank you so much for listening to me today.
Thank you. Is there one question from the audience? While you're all busy scanning the QR code.
That's better. How many have subscribed till now? Raise your hand if you've subscribed. Good. Thank you, Justin.
Thanks.
Okay, thank you.
We have now the opportunity of listening more about Paul Tomlin's great work at Jamaica West Indies University.
August 1, 2017. I was appointed Dean of the Faculty of Medical Sciences at the University of the West Indies, Mona, Jamaica. The oldest medical school in the English-speaking Caribbean, 71 years old, 6,000 students covering a range of health professional disciplines and a wide mix of staff. New leader, new vision, new thoughts. What is my administration going to be about? Among that, the passion for social accountability. 2 years later, asking, reflecting, where has my leadership been? What has happened in 2 years? Leadership can be lonely. Leaders are often seeking feedback, hopefully good feedback. Always asking questions, thinking, what's happening? So I searched 16 faculty board minutes, 8 of them before I started as dean, 8 after, looking for some evidence, some connection that social accountability has begun to take root. Something is happening. I used content analysis, QD, A minor, all of that fancy stuff. And I found 3 references to social accountability in the minutes. A little bit disappointed. But I thought it would make a good, tough abstract, so I submitted it. And on reflection of that abstract, and within that disappointment and thinking about where I am with social accountability, where we are, I took a fuller view than beyond the faculty board. And I really, on looking on, said, hey, we were doing stuff in the 2 years. We've had social outreach, develop a strat framework, workshops, student projects. We did an ISAT review, the latest tool out from PAHO on the faculty and what's happening. I gave 3 new Dean's Award for social accountability to a range of faculty members and groups. People were excited about this. And really my reflection at the end of the day is that as a leader, championing social accountability We need feedback, but we have to look at our communication strategy, and we have to think about what it means really. And it's about telling a story to a large extent. Part of the leadership is really about saying, where are we going as a faculty collectively? And I think this story has to be told by everyone, not just the dean. We have to get everybody excited so that eventually at the campfire of the faculty board, we'd have a lot more discourse and a lot more content and a lot more things happening. But I feel satisfied that some stuff has begun to happen, even if the fires and the flames haven't yet blown over widely into a faculty board discourse. I'm very proud of the work that we're doing that has begun to happen, championing social accountability. And I look forward to helping to write the script with my students, my faculty, my community in the years to come. Thank you.
Congratulations, this is special. Any questions?
Question regarding, recently I learned about lobbying before meetings, and getting into the meeting with your foot on the ground, and you know exactly where this meeting is going. How much lobbying do you actually do before you enter into one of those decision-making meetings?
Yeah, I think if it's certainly a big decision to be made, one wants to consult and talk and bring all the partners together and all of the relevant persons. To a large extent, as Dean, you're also setting the agenda, setting the faculty board agenda for meetings. But what you try to do is to lobby. I still try to lobby without too much bias and to give people a fair chance to speak their minds, speak the truth, and then we come forward and we make a decision. So maybe lobbying always has a little bit of a biased word. I try as much to communicate, keep the floor open, but let people be prepared and be aware for what's coming on the agenda.
Okay. Thank you, Paul.
Thank you.
Let's have Kalyani Premkumar.
Hi everyone, I'm Kalyani Premkumar from College of Medicine, University of Saskatchewan, Canada. And this is relating to the study that has been done on the effect of text messaging on the awareness of diabetic retinopathy and eye care in Aboriginal people. So the study was done in Saskatchewan, and Saskatchewan is a prairie province in the heart of North America, and Saskatoon is a large city with about 270,000 people, and of which 1/10 of the population is Aboriginal people. And this study was done on these individuals. And it's well known that everyone knows about the Aboriginal population, how they have a unique culture, food, beliefs, and so on. And so the strategy that you use to approach them has to be totally different and ensure that the whole community is incorporated. So there is an increased prevalence of diabetes in the Indigenous population, and according to statistics, 4 times more than the non-Indigenous population. And as you all know, diabetes has multiple complications, and one of them is diabetic retinopathy, and we were focusing on the diabetic retinopathy. Just look around. Everyone has a smartphone. Did you know that 90% of the global population uses mobile devices? And according to statistics, there's an average of 3 hours spent by people on mobile devices. So we chose to use mobile health, that refers to public health practices supported by mobile devices, to increase the awareness and problems relating to diabetic retinopathy. So what did we do? We thought we'll get text messages and convey it to them. So we recruited from this community, using community elders and support groups to volunteer to participate, and we had about 78 of them. And using their input as to what they're aware of, what their needs are, as well as drawing in experts of eye care, from diabetes, indigenous population, and physicians and so on. We came up with text messages and ensuring that they were applicable to that population that was going to be sent. We actually did a pilot study and to ensure that it was received well and smartphones were used. And what we did was send a message over 12 weeks, around 8:30 to 9:30, and did a pre and a post survey using the knowledge, attitude, and practice changes in these diabetic women and at risk of them. And also, we did sharing circles and got them to give us input as to the effect. And did you know what we found? We found that there were changes, significant changes in the knowledge, attitude, and practice of these people who received these messages. And also it affected them holistically, spiritual, emotional, physical, mental, the whole, holistically. And that was by qualitatively analyzing the input that we got using the sharing circles. So this provides evidence that mobile technology can be innovatively adapted and integrated for health education in different populations, but we do need to use a specific strategy for each of those populations. And it has the potential to motivate and empower and provide support, not only for just prevention and management, but also to reduce the risk of complications as a result of chronic diseases. Thank you very much.
Thank you very much, Karan. Any questions from the audience? Yes, please.
Thanks. I take it from that there was really a well-developed feedback loop then occurred between the text messages and maybe the health practitioners. Could you describe that a little bit more?
I'm sorry, how did I get the feedback?
No. I'm saying it occurs to me from what you were saying that it actually developed a strong feedback route between the text messaging and the person and the health professionals that were looking after their care.
That's
right. Could you describe that feedback loop in the real life a little bit more?
In real life, we brought in people who are already having community support groups in Saskatoon. And these text messages are validated and reliable, and because it was done in a specific way, and it's not those text messages that has to be used only in that population, it can be used, and we have a whole lot of validated text messages relating to diabetic retinopathy that others can use. So the same phenomena, if each of us adopted, because we do have health professionals and who have played a part in this, we could all, as a collective group, family, develop for multiple chronic diseases. And given that mobile devices are embedded in our lives now, we could use it for various chronic disorders.
Thank you very much. Using what we have available, simple things that we may not really notice, and then coming up with good strategies. Thank you very much.
I'd like to invite Anshu. Thank you very much.
Good morning. Benjamin Franklin once said that change is brought about when people who are not suffering feel equal need for change than those who are. At Sevagram, every undergraduate student goes through a community immersion experience. Every new batch of students adopts a nearby village, and every student is allotted 3 to 5 families who they follow for the rest of their MBBS course. In the beginning, for 2 weeks, the whole batch stays in that adopted village and lives and learns with the villagers. But the question which came to our mind is, do students actually learn from this community immersion experience? And if they did, what were they imbibing? To know more, we taught students and discussed with them the importance of reflection and reflective practice. We shared with them samples of good reflective writing and simply asked them to write their reflections daily during the 2-week social service camp that we organized in the adopted village. I'd like to share with you one simple story. One of our medical students found an open drain flowing in front of the homes of her adopted family. And that drain was a breeding ground for mosquitoes and vector-borne disease. When she brought this story to the notice of the faculty, they decided to use this opportunity to show her the process of change. She was given a chance to attend a meeting in the village where the entire village leadership was present, the community health workers were present. She presented her case. Contrary to her expectations, despite her enthusiasm, she did not see immediate success with what she was asking for. Instead of being disheartened, a cursory glance at the reflection she wrote at the end of this experience show that one experience taught her how healthcare is intricately woven with the social, economic, and political dimensions. Perhaps that one experience taught her more about the social determinants of health than any textbook ever would. We believe that introducing reflective writing early in the curriculum plays an important role. Our experience shows that students, they tend to focus on things better when they're asked to write reflections. They observe things differently, as well as they look at things beyond health. And we believe that reflective writing can be a powerful instrument for change. The stories that we have read through these reflective pieces might be small, but clearly the impact on the growing minds is huge. Thank you very much.
Thank you, Anshu. I'm really interested for you to tell us just a little bit more about the immersion. So the students are there for 2 weeks, and then did you say they follow their adopted families?
So the process is that as soon as the batch comes there, a village is identified, the population is already there in the records. Every student is allotted 3 to 5 families. And when they stay in the community, the Faculty of Community Medicine, they work with them, they give them specific themes, like they have to interview the members of the family, they talk about the health, hygiene, the ventilation, the other social determinants, and they have a complete record. Now with online data, it's possible for us to have a record of the entire village. Now, every week after the camp is over, or every month, they have one specific Saturday where they go and learn about a specific topic. Like 1 week it could be immunization, 1 week it could be nutrition. So they're asked to go and interview those people and learn from them every week. And this goes on till they complete their MBBS course.
What a fantastic longitudinal program. Thank you.
There's been a lot of information, so I'd like to introduce our final speaker, Shannon Widderick.
Thank you. Good morning. What if there were a group of healthcare providers who were highly skilled, fit for purpose, and responsive to population needs? What if this cadre could be trained in less time and at less cost than physicians, while ensuring high-quality patient care? And what if I told you they've been delivering care since the 1890s? Accelerated Medically Trained Clinician, or AMTC,
is a designation encompassing such professions as clinical officers, physician associates, doctor's assistants, and health officers, to name just a few. Globally, there are hundreds of thousands of AMTCs practicing across at least 46 countries, with a scope of practice which ranges from general medicine in the clinics of Malawi to specialist care in Kenya, from general surgical practice in Mozambique to cardiac surgery in India, from medical education in the United States to the coordination of health centers and care delivery across rural and underserved communities in Ghana. Worldwide, AMTCs are a vital component of the delivery of primary health care. However, AMTCs are not recognized internationally as a professional group. Training and regulation is largely dependent upon the health, education, and government structure of each country. For example, in Israel, curriculum, training, and registration is wholly designated by the Ministry of Health, while in Canada, education and training occurs at the university level, and regulation is decided upon by the province. This disparity among AMTC training and governance, coupled with a lack of international recognition, has led to the isolation of this important healthcare cadre. Together with colleagues from around the world, our AMTC Collaborative Working Group is collecting information regarding best practices for teaching and for regulating. Our survey of AMTC educators in 19 countries has begun to reveal training practices such as problem-based learning, lived experience, and service-based learning are common themes. However, lecture-based format remains the main educational platform for some programs. With the support of groups like FAMER, we are planning faculty exchanges to improve training and encourage growth. With global collaboration and recognition, AMTCs can be a more integrated part of the solution for health inequality, social accountability, and global population health. Thank you.
Thank you for your presentation. I was just remarking to someone this morning that I have 2 physician assistants I work with, and every day that I've been here from 2 to 4 a.m., I'm exchanging emails with them while they take care of my patients. Are there any questions related to advanced medical clinician trainees?
Great presentation, by the way. You alluded to some issues between governance with social accountability with respect to the provincial governments administering the healthcare system and then the universities training the health workforce. Just curious if you could expand on that for me a little bit more.
Thank you. Yes, so my understanding from colleagues in Canada who have provided us with information is that there are, I believe, 4 programs, PA programs in Canada with PAs coming out of military initially there, and then universities, private universities have developed their own programs, or non-military universities. And there are a number of PAs practicing in Canada. However, there's no national need for registration. And in fact, in Ontario, the profession is completely unregulated, but does in fact employ the highest number of PAs. So this provides us with some challenges when trying to understand both the scope of practice and ensure that quality health care is being delivered to the right people and in the right way, and that we fully understand our workforce capacity and best practices for training. I hope that answers that. Thank you.
Thank you, Shannon. Thank you all our presenters for those beautiful presentations, and all of them very inspiring, and a lot of work has gone into it. So we know that 5 minutes is not enough, but you've made sure that we understand a piece of what you do. So thank you. Now I would like to open it out to the audience for questions and comments and a discussion.
Just had a question, I think it's Dr. Ashnu, is that how you pronounce it? With the families in the program, how do they show their interest in being involved?
The camp is organized with the help of the community. The village helps us to house all the students for the next 2 weeks. During the course of the camp, all the health facilities, the OPDs are run free of cost to all the villages. So all the specialists from the hospital, they come over there. If there's somebody who requires hospitalization, they get a 50% off from that 2-week course. So we also have a village insurance scheme where the whole village is insured, and for the next 1 year, they get discounts on the hospital stay. So it's like a give and take kind of relationship.
Yeah. Thank you. Any other comments?
I have a question for Krista, and I'm sorry I didn't manage to get it in during your presentation. I wonder whether you've considered including vets as part of the interdisciplinary team.
No, actually, that hasn't come up yet. We've just started reaching out to other universities that also have rural schools, if anyone's interested in coming along, and reaching out to other allied health professionals and trying to extend our reach as possible. But that's an interesting element as well, is the veterinarian care. Yeah.
There's a question from David.
I really enjoyed this session, and I want to congratulate everyone for being part of it. I mean, years ago, I remember this guy, Art Kaufman, I don't know where he is today, but who said that one of the great things about the network is that it's like going to a bazaar and somebody's selling pearls in one area and someone's selling baskets someplace else, and one person yells a little bit louder than the other to attract our attention, and somebody has lots of colors to attract attention. And I thought today, despite the lack of a song, people really had a way of telling their stories. But the stories that work best seem to be the ones that are, and what makes them memorable, seem to be ones that are very specific and sort of pull at our heart. And I'm kind of interested, among the people who made their presentations, how do you decide what to talk about in just 3 minutes? And whether to try to be at 30,000 feet or at 2 feet? And how to tell a story that would be memorable for the people in the audience? It's really a hard act. And I'm just sort of curious for if some people would say something about that.
Yeah, okay. We have some. Kalyani is here. Kalyani. And as you get the microphone, Arthur Kaufman has a nice TED talk on YouTube that really is intriguing. So you could look that up. It's a bit of like what this is about.
And just to bring to your notice, to all the speakers, thanks to the event planners, they had sent a guide specifically for oral presentation. And it wasn't just a one-pager or something. It was a really well-planned, structured ones, which made every presenter think about what to focus on, and how to bring it up. And I'm sure the others will agree with that. And that was really helpful. And I think that is something that could be made public again for all speakers, because it does have quality of speaking.
Good.
I think this was one of the best experiences I've had at this session also. And the problem is there's so many presentations and there's a bunch of people I want to talk to, but I know I'm not going to do it. It's going to go out and then I'm going to get like a bun or something. And then they're off and I can't find the person I'm trying to talk to. And I just wonder if we could have like speed dating, just that after these talks, then they're in a room and everyone can talk to exactly, I mean, really put it, because I got questions I got to ask and I know I'm going to miss Zambo. I'm going to, I want to know, I got to ask someone about something, but I'm going to miss it. And if it could be followed by something that we really can sit down and get into depth, that would be spectacular for me.
Great idea.
So a younger person told me, insulted me in public. Okay.
Yeah.
And we're going to hear a high advertisement also. But
any other comments? Because there's somebody, but we could also have the last 15 minutes, and people get together and talk about this work. But let's hear from Owen first.
Sorry.
Look, I was really struck by a number of the presentations where people are opening up, I guess, their practice or their way of looking at education towards that. I mean, it's really cross-professional or cross-industry development. So again, taking from the earlier comments about maybe inviting architects or engineers or veterinarians into the business of TUFH, that sounds like we've got a substantial sort of groundswell already developing from people in their working communities. It's fantastic. Seems timely. Great, thank you.
Thank you, Owen. So if there are no other questions, what if we practice what Arthur has suggested? If you have questions, let's get together, discuss them, go to different people that have presented and ask them questions and discuss with them for the next 15 minutes as we come to the end. But let's first give our presenters a round of applause. And our panelists as well. Okay, let's get going. Let's talk to each other.